So in moving on to our next speakers, we have the dilemma of looking at ADCs and really trying to figure out the efficacy versus the toxicity of these new emerging agents. And breast is always developing new drugs. We have a lot of funding, and every 6 months it seems like, or less, it seems like some new drug is coming out, and it is. It keeps them on their toes, but it also keeps everybody else who's a part of the team on their toes. So Dr. Tang, who many of you know, and I have had the pleasure of working with him not only here at LSU, but also at the University of Mississippi Medical Center. He is a world-renowned researcher. He leads our phase 1 trials over at the Cancer Center at University Medical Center. He is certainly a board-certified medical oncologist, but has particular interest in bringing newer modes of treatment and targeted therapies to those who need it. He is well, I guess your title is professor of oncology here at LSU. And as you see on your program that Dr. Locke is supposed to be the counterpart in this pro and con in talking about ADCs. But just like everybody's filling out their brackets and replacing, we have a wonderful, wonderful stand-in who is Dr. Taylor, and she is representing the con side of ADCs and how we should be using them. She is a board-certified medical oncologist at Ochsner Health. She specializes in breast cancer treatment, completing her fellowship at Emory University. She is currently the Associate Program Director at Ochsner and is actively involved in training the next generation of oncologists. Her clinical focus is on outcomes and making sure that outcomes for her patients are beyond par. So I will have them come in that order, Dr. Tang and then Dr. Taylor.
So this is the advance, right? Mm-hmm. Thank you. I want to thank the organizer for inviting me to speak. Of course, I want to thank Dr. McKinney for your kind introduction. So today, I'm going to talk about a controversial issue, that is, do you need a biomarker to offer patient antibody drug conjugate or ADCs? So I'll represent the con side, while Dr. Taylor will talk about the pro side. And this is a very controversial topic, of course, and many of my talks are based on my own research. Some of them are not published. So before my talk, I want to do a quick poll and to see how you feel about whether we should use biomarker to offer ADCs. And I'll give you 3 options. And the first is we should test everybody in order to offer ADCs. Let's see a show of hand. Should we measure biomarker? Well, second choice is no, we don't need biomarker. We can offer ADC to anybody. Let's see a show of hand. Okay, I guess everybody go for the third option then, that is maybe, which is obviously what I'm going to recommend. I'll tell you why. So I'm glad we got a consensus already, but unfortunately I still have 15 minutes to give. So when I was doing my PhD over 40 years ago, my thesis was to clone a gene which requires raising many monoclonal antibodies. At that time, after we raised all these monoclonal antibody, we thought, would it be nice to attach a toxin to the monoclonal antibody so we can use it as a magic bullet to kill the cancer, specifically the one that expresses certain biomarker. So of course, nowadays, those dreams in the lab have come to fruition. We have a lot of ADCs on the market now. The way ADC works is that we have a monoclonal antibody against the biomarker. Now attached to the monoclonal antibody is a payload or toxin through a linker that make the payload inactive until it is reach the tumor, enter the cell, and the linker get cleaved, and the payload release. It kill the tumor in a suicide fashion. This is how ADC works. And of course, TDM1, as you know, in breast cancer, is one of the first modern ADC developed. I was fortunate to be one of the co-investigators who studied this drug through the media trial. Of course, it is a Herceptin linked with the EM-tensine through a non-cleavable linker. And this is how ADC works for CAGLA. Of course, through the trial, we know that this drug fulfill the requirement of ADC. That is, it is not very toxic because the payload is only released inside tumor cells, not systemically. Therefore, it has minimal toxicities. But then we ask the question, even with CAGLA, we still see some toxicities. It should be toxic-free. Where does that toxicity come from? See, since I was one of the PIs, we did more research, and I thought perhaps the free payload got released after cell broke down, and it released the payload into the blood, which caused toxicity. That's the only place where the free payload could come from. If that is the case, I further hypothesize we should see a correlation between toxicity of TDM1 and the degree of tumor response, and then patient survival. So we did a multinational study involving Canada, where I trained my PhD from, and Georgia and Mississippi. We collected tissue of the patient who received CAGLA and see if we can correlate their toxicity with their survival. Of course, it's a positive trial. Indeed, if you look at on the left side, if you have higher toxicity, we have toxicity sum score, where we sum up all the toxicity from the liver, from the blood, and others. We make a toxicity sum score. And this sum score is highly correlated with the survival. If you have a toxicity 2, your survival is longer than patient who only have a toxicity 1. If you look at the right side, if you have toxicity 3, patients survive even longer than toxicity 2. Again, confirming our hypothesis that for TDM1 with a stable linker, the toxicity is actually good for longer survival or response. Now, we have a conundrum now, because we know that of many ADC out there, some are less toxic, such as CAGLA, some are more, such as HER2, and some ADCs require biomarker testing, while others don't. It doesn't make sense. Why don't we have a uniform approach? If an ADC, you go for a biomarker, this should be toxic-free, right? So those are our current conundrum. Indeed, this is from my unpublished data. It's being published, by the way. If you look at all the current available ADC on the market, half of them require biomarker testing with a companion diagnostic test. The other half in the bottom do not. Why? It's ADC. You've got to measure the biomarker, right? That's how monoclonal antibody works. So again, when you go back to the original HER2 trial, that's the Destin Breast 01 trial, when it was published as a phase 2 data in San Antonio, I was impressed not only with its efficacy, but also with its toxicity. I asked why? Why are we seeing toxicities? And in fact, when you compare the CAGLA's toxicity, as you know, its payload is TDXD, which is a topoisomerase I derivative. Its toxicity is actually more than its parent drug, such as topotecan, irinotecan. Why? This is a daughter drug. Why it is more toxic than the parent drug? That's my further question. And indeed, when I compare the two drugs, TDXD and CAGLA, one has, they are both targeting HER2 as a target. One drug has a lot more toxicity compared to the other. Again, you ask why? They are both ADCs. So our hypothesis is that, perhaps, it is the linker. Because when I compare the linker, TDXD has the tetrapeptide linker, which is cleavable. bipeptide disc, whereas CAGLA has a non-cleavable linker with a thiol ether linker. So our hypothesis is perhaps, with the cleavable linker, you release more payload before the ADC even reach the tumor. Therefore, you have higher free blood concentration. As a result, you would have more toxicities. Number two, since you have a lot of free payload in the blood, you probably don't even need a biomarker to act, which you don't even need a HER2 to be effective. And finally, of course, we look at the survival. Our hypothesis is that perhaps those ADCs with a cleavable linker should have more efficacy and result in longer patient survival. So that is our original hypothesis. We actually proposed this, several years ago. We were the first in the field to propose this hypothesis and published the data in ASCO, again, through a meta-analysis where we divided all the ADC in two groups, 11 of them. One group with the cleavable linker, the other group with the non-cleavable linker. We asked those three simple questions. Does the group, different groups have different free payload in the blood? Number two, do they have more toxicity or less? And number three, efficacy, which we couldn't determine because this is a retrospective meta-analysis. This is from the study showed indeed it fulfilled our hypothesis that those with the cleavable linker have higher free half-life or free payload in the blood, and they actually are more toxic. So we chased up that study with a subsequent systemic review and meta-analysis. And this is just published last year. And this meta-analysis basically represented two systemic reviews. And we searched all the publications of ADCs in the literature. And it represents 40 clinical trials with 11 drugs, FDA-approved drugs, representing 7,000 patients in each arm. And we asked, again, the same question. Do these two groups have different free payload? The answer is yes. Those with the cleavable linker have a lot higher free payload in the blood. Number two, which one has more toxicities? Of course, the answer is yes. Those with the cleavable linker have a higher degree of systemic toxicity. Even if we factor in the DAR, which is the antibody to drug ratio, and it still shows that those with the cleavable linker have higher toxicities. So the conclusion from our own research is that, indeed, ADC with cleavable linker are associated with significantly higher serum-free payload concentration and systemic toxicities. And also, ADC with the cleavable linker would act in the biomarker-independent matter because you're going to kill the tumor with the free payload rather than with ADCs, whereas those with the stable linker kill the tumor in the biomarker-dependent matter. So, of course, our observations were subsequently confirmed with additional study, both clinical and preclinical. This trial looked at the same question about the activity of HER2 in HER2-positive tumor, dividing them up in HER2 3+, 2+, 1+. It shows consistent activity of HER2 even in patients with HER0 population, about 30%, showing that even if you don't have target, HER2 still works. Of course, the final proof that nailed the coffin is this study that was published from a Yale group, that was published in Nature last year. They proved conclusively with a preclinical study, indeed, HER2 is actually cleaved before it even reached the tumor. What study shows that, in fact, T-DXd in HER2 low and even HER2 negative breast tumor is independent of the HER2 expression. And you don't need a HER2 for the T-DXd to be internalized and kill the tumor. In fact, where does it get cleaved off? In the tumor microenvironment. In fact, as you know, when tumor breaks down, they release a lot of proteases. Most T-DXd were cleaved in the microenvironment before they reach the tumor by cathepsin L. So as a result, they release the payload before they even reach the tumor. And to follow up additional observation from the preclinical trial, again, a group from Yale is actually doing a phase 1 study to confirm clinically whether it's the case, because we now proved preclinically you don't need HER2 for HER2 to act. So they're going to do actually a study looking at HER2 zero population and offer those patients HER2 and see if they indeed respond. This is a bold movement, but based on preclinical study from their own group and also based on DAISY trial. So I think this will be a very interesting study to follow. So coming back to my initial question, do we need a biomarker to offer ADCs? The answer, to me, rely on the linkers. So it is, yes, you need a biomarker if you have a non-cleavable linker, but you don't if you have a cleavable linkers. Of course, there are many other factors that determine the efficacy of ADCs, including antibody binding affinity of ADC to the biomarker, drug-to-antibody ratio, or DAR, mechanism of action of the payload. You want to offer the patient a payload that has no cross-resistance with the prior ADCs, talking about ADC sequencing. More importantly, membrane permeability of the payload also play a role because they cause the so-called bystander killing. And finally, ADC induced tumor killing by ADCC through the immune system. So this is how I think we can put together how ADC would work, which is, again, being published. On this side shows the ADCs with a non-cleavable linker, where you got to have a biomarker to get in the tumor cells to be released, to release the payload inside tumor cells. Whereas on the right side are those ADCs with a cleavable linker, where the linker got cleaved up actually before they even reach the tumor, and the free payload get into the tumor to kill the tumor. So this is how those two groups of ADC works. And talking about next generation of ADCs, we know that ADC with a cleavable linker, they probably are more potent, yet they are more toxic. And those with a non-cleavable linker, they may be less potent, but of course they are much safer. So how to strike the balance, which is the theme of our discussion here. So I always say ADC linker is a double-edged sword, So therefore, to approach this balance or to increase the therapeutic index of ADCs, there are several factors we can take advantage of. One is tumor microenvironment, because we know that in tumor microenvironment, their condition is different from normal tissue, where it's more hypoxic, more acidic, and has more proteinase, where the tumor cell break down. And therefore, we can take advantage of this to generate what we call microenvironment specific or conditionally released linker, where the linker will be released in the microenvironment but not in the blood. So there's a novel generation of ADC being generated, and they include, of course, the novel payload that act cross-resistant to prior chemotherapy. There's site-specific conjugations. There's a bispecific antibody where they can actually target two antigens, or novel payload, or even dual payload. The ADCs can carry two payloads, instead of one type of payload. And you even have a peptide drug linker ADCs, where you can target the intracellular proteins rather than membrane proteins. And this is a summary of what they call ADCs with conditional release linker, what we call second or third generation. And those are linkers that are released by special protease-sensitive linkers, acid-labile linker, reducible linker, beta-glucuronidase linkers, double lock linkers, and iron labile linkers, and finally, even photosensitive linkers, where you just shine a bead of light to the tumor, and linker will be released in that spot, not nobody else. It will be very specific to target tumor, but not the systemic circulation. And finally, this is the slide I put together in terms of how we think the ADC works. Basically, if you have a conditionally released linker, and the linker will be released in the tumor microenvironment, then they'll enter the tumor cells by the free payload without the biomarker. So therefore, you can enhance the derivative payload to the tumor, but not to the blood cells. So I want to summarize what I discussed so far. And targeted therapy, of course, require biomarker testing if you do have a biomarker targeting agent. And controversy exists in biomarker testing in order to identify tumors that are suitable for ADCs. And ADC with a non-cleavable linker, of course, function in biomarker-dependent manner, while those with cleavable linkers, they function in both biomarker-dependent and independent manners. And of course, what we need is novel strategies to optimize ADC designs with the maximal efficacy and minimal toxicities. So on that note, I'll finish my presentation. I was going to do another poll to see if I have a swing your opinion after my talk. Since everybody went for maybe, I think I've done my job. Thank you.